Welcome to everybody who's joining. I'm just going to leave it a couple of minutes to allow people to filter through. We do have quite a lot of attendees today, so I want to just make sure everybody has a chance to join. Thank you. I can see the attendees are still continuing to trickle in, but I will start and people can continue to join as we're doing introductions. Thank you all very much for being here today for the VAMHN lunchtime webinar. We're the Violence, Abuse and Mental Health Network. We work to understand, prevent and reduce the impacts of violence and abuse on mental health. And this is one of a series of events that we've been running over the past year, aiming to bring the most recent and up-to-date research and analysis to our members with a real focus on the real world implications of that evidence. We are delighted to have Tim Woodhouse here with us today to speak with us. He is the Suicide Prevention Manager for Kent and Medway and a Winston Churchill Fellow who has investigated international responses to domestic abuse related suicide. We're of course meeting shortly after Ryan Wellings was convicted of assault and coercive and controlling behaviour, but cleared of manslaughter following the suicide of Kiana Dawes. It was a desperately disappointing verdict, and our collective thoughts are with Kiana's family. We're heartened that the police have spoken about their intention to continue bringing these cases to court following domestic abuse related suicide, and it really underlines our intention that we have to learn and respond to these cases. And as Tim will say, we're increasingly understanding just the scale of domestic abuse related suicide, both in the UK and internationally. So we're really pleased to be having this talk today. If I can just do a few points of housekeeping before I hand over to Tim. As this is a webinar rather than a meeting, you have all been muted and videos off as you have joined the call. If I can ask you to use the chat function to make introductions and to share resources. It's really good to know who's in the room. There's so much expertise here in the room today, and it's great to share that. If you would like to send through a question to ask to Tim, can I ask that you please put that in the Q&A box rather than in the chat? That just makes it a lot easier for me to see what's coming through rather than keeping an eye on the chat function and on the Q&A box simultaneously. Tim will be talking for about 20 minutes and then we'll have around 20 minutes for questions. I will get through as many questions as I can. Please do send them through as they occur to you, and of course during the discussion itself. Thank you again for being here. Thank you, Tim, for joining us. I'm going to mute myself and hand over to you. Thank you very much.
Thank you so much, Sian, and thank you everyone for coming along to this session today. I was told when I first started out my professional career that you should never start a presentation with an apology, and so I'm not going to start with one apology. I'm going to start with two apologies. Firstly, we've had major IT issues my end, and so I'm presenting on my son's very dodgy school computer, so apologies for that. And I've also got a 5-month-old puppy running around under my feet in and out of the garden, so apologies that if I might have to disappear and let her either in or out or stop a fight or something. So I apologize that this isn't going to be as professional as it should be and as I would like it to be, but we will just go from here. So thanks, Flavia. If you can go to the next slide. So some of you will know who I am. Some of you may not. So I am, as Sian says, the Suicide Prevention Programme Manager down here in Kent. I've been in that position since 2014. I'm an NSPA steering group member. I have just started my academic career. I'm hoping to get a PhD place at the University of Kent to research this topic. And as Sian mentioned, I've completed my Churchill Fellowship on this subject, which I'm going to be talking all about today. Next slide, please, Flavia. So just in terms of how I'm going to spend those 20 minutes, I'm going to try and bring everyone up to speed. Some of you will have heard me talk about my research in Kent before that we've done with our real-time suicide surveillance. I'm also going to talk then about my Churchill travels and what I found there, and then finish by talking about some of the actions that we can all try and take, or certainly campaign for in our respective positions. As Sian mentioned, we are talking about two distressing subjects, both suicide and domestic abuse. Please look after yourselves. I know you've volunteered to come along today, but just a reminder that I'm not going to be offended if you need to disappear, find a cup of tea, reach out for support using the chat line 85258 via text that's on the screen. Okay, next slide, please, Flavia. So it goes without saying that suicide is devastating, and the work that we have done over the last 6 years in Kent and Medway has, I think, been the first time that we've been able to quantify the amount of lives that are being lost by suicide amongst people who have been impacted by domestic abuse. Sian talked about the fact that these seminars are a really good way of showing the latest data, and I can share with you that we've updated the figures that you can see on the screen this morning. We literally got the 2024 figures from Kent Police yesterday, and so what you are seeing on the screen is hot off the press, and that is that 291 of our suspected suicides in Kent and Medway have been impacted by domestic abuse over the last 6 years. That's a proportion of 33%, which is way bigger, far bigger than we ever thought it would be when we started collecting the data 6 years ago. And just as a national illustration, if you extrapolate that 33% onto the ONS suicide figures nationally, it equates to about 1,800 deaths by suicide every year that have been impacted by domestic abuse. Next slide, please. But what everyone in this room that knows anything about DA will know is that that is going to be an underestimate, given how underreported domestic abuse is, both to the police, but also to friends, family, and other agencies. Next slide, please. Some of you will be interested in what we mean by impacted by. Well, there's quite a few different cohorts. The most obvious, I guess, is the victims. So, and we can tell from our data that yes, definitely there are victims of domestic abuse who are dying by suicide, and you can see the gender split on the screen there. I should point out I haven't had a chance to update these slides, so this is just 2018 to 2023 data. I'll be updating these slides very shortly. But you can also see that we are definitely seeing deaths by suicide amongst perpetrators of domestic abuse. The gender split there is much more heavily swayed to male perpetrators, perhaps not surprisingly. But then the cohort in the middle that we label both victim and perpetrators, actually, it's not we labeling it, it's the police labeling it. These are individuals who are known to the police as both victims and perpetrators of domestic abuse. And that's a cohort I'll come on to in a minute. Next slide, please. I'll skip over this one briefly, but just to give an illustration of the type of quantitative work that we're able to do with the real-time suicide surveillance set, we collect things like when the last known domestic abuse incident was before the death, and you can see the breakdowns there. Key thing to highlight here is that we are seeing deaths right in the middle of the abuse, so 24 hours earlier within 12 months, but we are also seeing deaths amongst victims many months, over a year later after the abuse has stopped, which just highlights that long-term impact of the trauma. Okay, next slide, please. How do we, as in Kent, compare with other parts of the country and other parts of the world? Well, other parts of the country is difficult, stroke impossible to answer, because we think at the moment we're the only part of the country that's collecting the data in the same way, although that is slowly starting to change, and other counties are starting to collect it. So hopefully we'll get a bit of a better picture shortly. But in terms of globally, though, the major study that was released last year from Australia highlighted over a much longer time frame and a much larger sample size that their findings were 25% had been impacted by domestic abuse. So 25% is not the 33% that we found, but it's in that same ballpark, and it's still a considerable amount, and it's way too many lives being lost. We also had the report released last year from the National Police Chiefs Council, which highlighted that according to their database, they saw more suspected victim suicides following domestic abuse than there were intimate partner homicides. Next slide, please. I think that's a crucial bit of evidence. And if you put that in another way, it means that the person most likely to kill a victim of domestic abuse was themselves. And I think that has major implications for the way the domestic abuse sector responds to domestic abuse, and we as a society respond to domestic abuse. Quite understandably, the vast majority of the domestic abuse sector's response to a perpetrator and the potential harm, is to try and put safety measures into place to keep the individual, the survivor, safe from harm from the perpetrator. That's quite understandable. We need to do more of that. We need to get better, even better at that than we are already. But in addition to that, we also need to take much better account and introduce much more measures to keep the person safe from themselves, from the risk of suicide, because that's where the majority of deaths are happening. Next slide, please. So in Kent, we did some qualitative work as well. We asked victims of domestic abuse who had attempted to take their own lives what drove them to try and take their own lives. There is some sound clips on the next slides. So Flavia, if you could go ahead.
I knew that he was going to kill me, so it wasn't a matter of choosing to die, just who was going to do it.
And when we did that qualitative work, we found that, I guess understandably, there were no story with the same, lots of different explanations about what drove them to attempt suicide. But there were four kind of main themes. And this first cohort was so convinced they were going to be murdered by their perpetrator, they didn't want to die, but in an attempt to control the manner of their death, they attempted suicide. Next slide, please.
I thought I was worthless, like I didn't deserve to be alive, and that everything they said was true. I was horrible, and that the only way out was for me to die.
So that's the cohort that these people didn't believe they were going to be murdered, but they were just so worn down, their self-worth was so evaporated by the perpetrator that they genuinely did think the world would be a better off place without them. And that's why they attempted suicide. Next slide, please.
You go into survival mode. You're hyper-vigilant. It's exhausting and tiring. I was sick of fighting. I was sick of surviving. I knew when I woke up that day I would attempt suicide.
So this third cohort, they don't think they're going to be murdered. They don't believe the lies that they're being told, but they just want the abuse to stop in whatever form that abuse is taking, and they cannot figure out another way of making that abuse stop. Next slide, please.
I felt broken. I felt so many emotions: shame, hurt, fear, grief. I felt like damaged goods. I couldn't sleep at night. I was having flashbacks, and he was on Tinder finding the next victim.
And this highlights that the point I was making earlier about the timescales. We are definitely seeing deaths in the period of the abuse is happening, but we are also, as this person told us, seeing that the suicide attempts can come many months, even over a year later, when that impact of trauma really hits them. Next slide, please. So we've done a bit of quantitative work, we've done a bit of qualitative work, but I'm not standing here or sitting here in front of you today saying that we know everything, because we really don't. We are only just starting to scratch the surface of what questions to ask. And you can see on the screen that I think there is huge gaps in evidence everywhere. I mentioned right at the start that I'm trying to apply for funding to do one PhD. I think there's at least 100, 200, 300 PhDs waiting to be written on the various different nuances that we see in this issue. Next slide, please. But coming from a public health background, I don't want to wait until we know everything before we try something. So that's why I applied for my Churchill Fellowship. And I've been around the world, and I have highlighted some actions which are being taken by people around the world, which I think if we can implement here would have a positive impact and reduce the risk of DA-related suicides. So that's what I'm going to talk you through next, please, with the slides. This is the front cover of my report. You can see that it's entitled 66 Ways to Reduce DA Suicides. It's purposefully solutions focused. It's not a academic theoretical examination of the issue. I'm hoping to do that as part of my PhD. This is much more a solutions focused thing. And you can see at the yellow in the bottom, I really hoped it would be published by now. We're still in the final week, still just trying to finalize the launch event. And as soon as I can get it out to you, I will do. But next slide, please. If you've not heard of a Churchill Fellowship, they are phenomenal. I won't spend too long on this, but it's you really should check them out. If you want to go anywhere in the world that you want to and research anything you want to anywhere in the world, check them out because they are phenomenal. Next slide. Because they pay you to go to places like Iceland. So this is me in Iceland. And next slide. This is me in Slovenia. Next slide. And this is me in the States. And I show you those slides partly to get your desire to do your own Churchill Fellowship up, because I do think I definitely would recommend it to everyone, but also to highlight that in addition to doing your research, you can get a bit of free time and do amazing things. But it wasn't all play. It wasn't all going to baseball matches. I spoke to a huge number of people, many of whom you can see on this screen, and then also the next slide. Thank you. And then for the next couple of minutes, I just want you to hear from 3 different people that I spoke to over the course of my travels, who really opened my eyes up to different aspects of these DA-related suicides. So in the first slide, you are going to hear from Tia.
He was smiling, like smiling the most evil smile I've ever seen in my life. And he said, "You thought you could get away from me, didn't you? You thought you could leave me." And it was at that moment I knew I was in real trouble. I screamed, I protested, I told doctors, I told social workers, I told psychiatrists, I told friends, I told everybody. But nobody believed me. It was already too late at that point. He made them believe I was a crazy person, right? All I wanted was to be believed about the abuse and what he was doing to me. If literally one human being had looked me in the eyes and said, "I believe you," this would have been a completely different story. But nobody did. They laughed in my face, they bullied me, and I tried to kill myself.
So Tia was, well, firstly, I should say that Tia's in a much better place now. She's doing really well. But yeah, Tia told me that they tried to reach help. They tried to do the right things, like all of us would encourage people to do. She reached out for help, but the support that she got was virtually non-existent and actually made things worse. So it just highlights the importance of services to get that first response right. Next, we are going to hear all about Essence.
Take Essence, for example. She was being choked and pinned against the wall by her former partner who had abused her for months. After the incident, she called the police, but because he had a visible scratch on his chest from where she had tried to defend herself, she was the one arrested. I asked him to please leave me alone. It was the only time I stood up for myself. She was convicted and court-ordered to attend and pay for a 30-week anti-violence intervention. Her attendance was mandatory and clashed with her work, so she lost her job. Essence's single act of self-defence and violence eclipsed her entire history of victimisation and led to an entirely disproportionate systems response. This was exceptionally damaging to her physical, financial and emotional well-being.
And you can understand how, after being the victim and victimised and abused for so many months, the one time she fights back in self-defense, she's the one that gets arrested, and then a whole spiral of system responses led her to losing her job. And you can understand why that's impacted her mental health so tragically. And finally, we're going to hear from Julie, who highlighted my eyes to a different aspect of this.
My ex-partner was arrested for stalking me and then killed himself. He left a suicide note blaming me for his death. We have a 6-year-old daughter together. Off the back of his smear campaign, his friends and family continued his abuse. They tried to change the locks of my house. Their solicitors threatened civil and criminal remedies against me. It's honestly a shit show. His suicide is an act of misogyny and coercive control. There's no part of our lives that's not been impacted by his decision. Our hearts, our bodies, our mental health, my career, our friendships, and our capacity to exist fully in the world. His cruelty is overwhelming. On bad days, I wrestle with the shame that maybe I am to blame for his death. By leaving, by protecting my daughter, by calling the police. His friends and family are quick to give me that blame. But the fact that you choose to not put up with somebody else abusing you, that doesn't make you responsible for whatever they choose to do next.
Julie highlighted to me that when she first went to both suicide bereavement services and also domestic abuse services after her perpetrator's suicide, the response that she got both times was, oh my gosh, you must be so relieved. You must be so happy that he's dead and the abuse is over. And of course, that's exactly not where Julie was. For a start, the abuse wasn't over. It had just been transferred and onto his friends and family were continuing the abuse. And secondly, she never wanted him dead. There was no part of her that wanted him to die. She just wanted the abuse to stop. And of course, she's now left, and her daughter is now left with a lifetime of messed up emotions about the whole issue. I think her description of his suicide as an act of coercive control is absolutely right. I think it's the ultimate act of coercive control, really. But that's for a further explanation another day. If we move on to the next slide. So this is where my report comes in. The 66 recommendations I've grouped under 10 domains, and you can see them on screen. I won't read them all out, but absolutely we need to do better support, give better support to the women and girls who are being abused. I think we need to give different support, but equally better support for men and boys who are being abused. We absolutely need to put more money into perpetrator services because that's where the vast majority of the prevention will come from. But we also need to understand this cohort of people who are known as both victims and perpetrators better. And again, won't read them all out, but you can see number 10, we absolutely need to do far deeper depth and quality and quantity of academic research. You can see teasingly the 66 recommendation that I think is the game changer. If you go on to the next slide, I'll explain about what that is. And critically, I came very quickly to the realization that this issue is way bigger than just me. It's way bigger than one Churchill fellow doing a very well-meaning report. If my extrapolation is right, and we are nearly 2,000 deaths a year of DA suicides, it needs a national response. I do think we need a national task force or similar to be brought together to understand and explore every aspect of this and to collectively agree a national action plan. Crucially, it can't just be from the DA sector, or it cannot just be from the suicide prevention sector. We need both cohorts to come together, and that's why it was pleasing to speak to Sian earlier and hear that there are so many people from the different sectors here today, and hopefully what I can do is try and start that conversation. So that's the 66th recommendation. I will just quickly, before I finish, go through some of the other recommendations. So on the next page, and again, some of the more detailed recommendations. These two are very simple and something that we could probably all change in our practice today, tomorrow, if we wanted. And that is when we are working with victims of domestic abuse, either male or female, please ask the question, are you feeling suicidal now? Have you ever made a previous suicide attempt? Because without answering or knowing the answers of those two questions, I don't think you can do recommendation number 9, which is creating a safety plan which incorporates both the risk of harm from suicide as well as the risk of harm from the perpetrator. We could make those changes tomorrow. We could absolutely ensure that we ask questions about suicide tomorrow of every domestic abuse victim survivor that we're working with, and we can change safety planning templates. I've got a meeting next week or a couple of weeks in Kent with all the DA charities in Kent to try and make sure that we're all working from safety plan templates that include the risk of harm of suicide. Next slide. Absolutely the same. I've highlighted that MARAC processes and policies and templates and bits of paperwork should all be including the risk of harm of suicide as well as the risk of harm from the perpetrator. Next slide. I do think this is a massive issue around counter allegations, dual allegations, violent resistance. I think people who are known as both victims and perpetrators are at particular risk of suicide, and we need better training for all frontline professionals in this area. Next slide. Just to pick up on Julie's situation, we absolutely need to get better support, both whether that's in the form of a guidebook. From those of you from the suicide prevention sector will know what Help Is at Hand is. It's a brilliant guidebook, workbook for people who have been bereaved by suicide. We should be able to do the same for people where domestic abuse was involved in the death. Next slide. It's ridiculous to me that Kent and Medway are the only part of the country that have got this extent of data. We need it to be national. We've got a national real-time suicide surveillance system in place in this country, but they do not include domestic abuse as a field of data collection, which is just so frustrating. I'm hoping that the Department of Health will change that quite quickly. Next slide. And then finally, we need to do far greater amount of research amongst all the different aspects and nuances that you can probably imagine, but I've listed some of them there. And then my final slide is just what I think might be the 3 most important insights from my work. And that's the first is just the scale of this issue. Over 1,800 nationally, I think, and it's more people are dying by suicide, more victims of domestic abuse are dying by suicide than are being murdered. And I think we need to, as a society, understand that and respond appropriately. Secondly, the point again about people known as both victims and perpetrators being at particular risk. And then finally, I think when a perpetrator takes their own life, it's not okay. We shouldn't be accepting that as thinking, okay, well, the abuse has stopped. I believe it's the ultimate act of coercive control. And then as commissioners of services and service providers, we need to ensure that those survivors get the long-term specialist support that they're going to need. Thanks, Sian. Thanks, Flavia, for doing the slides. Won't go through the further information and support, but there is a few more slides there, which you'll see when they get sent around with some templates that we've created in Kent and Medway.
Thank you so much, Tim, for your presentation. It's incredibly important, incredibly powerful. I think it's really striking the statistics that you have shared on the proportion of suicides that are domestic abuse affected and how many lives are being lost as a result each year. Also, the point that you make that more people are affected by domestic abuse, suicide than homicide each year is staggering. so powerful to hear the words of survivors directly. So thank you for including those in your presentation. And I think it really did draw out the ways in which so many survivors are being let down across multiple sectors and services, and how much more there is to do to improve practice and also improve knowledge in this area. So thank you. We do have questions coming through. Some of those questions are we sharing the slides? We are sharing the slides. We will share a link to the recording, and that will come through to the email address that you signed up with on Eventbrite. So they will come through to you in the next couple of days, along with some of the resources that Tim has kindly pointed us to as well. Can I ask a question from Lucy Allwright? The charity I work for supports mothers who have faced domestic abuse and child removal. I wondered about whether you have found data that highlights the ways in which children are used within domestic abuse and mother suicidality. Also, how can we access Kent data, and is there information on parents in there?
So I can send the link to ensure that the link to the Kent data is sent around with the slides, because we've got some publicly available stuff on our website. Short answer is no, though it doesn't include parents. What we are hearing is anecdotally, yes, absolutely, children are being used by perpetrators as a way of furthering the abuse on victims, and that will absolutely have an impact on people's mental health. It's absolutely one of the areas that I think needs further research, and I imagine that quite a lot of my answers to these questions will be, we don't know yet. We need to do much more deeper and further research in this area. We're just about, well, we do collect data on the number of dependents that people die have, but that's not quite the same as really understanding the nuances of how that relationship works. Obviously, domestic homicide reviews are a really good place to go in to do that deep dives, or the domestic abuse related death reviews, as they're probably now known in most parts. We need to get better at learning the lessons from those, and I think Sarah Danger and colleagues might be on the call. I know she's looking at some of that within her PhD, so maybe over to you, Sarah, in future as to whether that's something that comes out of those reviews that you're looking at.
Thank you. Another question from Viv Bickham. I agree with mental health support. My question is, do you think social care, both for adults and children, understand the issue of capacity in domestic abuse cases, especially when the Care Act 2024 has case law that links to CCB legislation that their capacity is compromised, yet they are left unprotected and often not assigned a mental health social worker or IDFA that they should be entitled to? Is this a training or a systems issue?
Wow, what a good question. It's my feeling is that some social workers will be excellent and really understand these issues, and maybe that's a training thing. It's also an experience thing. I also think, just to really fudge the issue though, I think it's probably a systems thing as well, in terms of, we know that all services are dramatically underfunded. I mean, drastically underfunded, and therefore just that the time and space to really consider every case in as much detail as we would ideally like to just probably isn't there at the moment. So I think, yes, it's partly a training thing. So partly there will be some social workers who are better than others, as in every walk of life. But I think probably fundamentally it's a systems thing. There just isn't the capacity and the funding in the system, or the number of social workers in the system, to really allow each case on the caseload to be dealt with in the best way possible.
Thank you. I'm reading as I go, they're coming through. I feel domestic abuse and mental health services are very siloed from each other and often work very separately. What you envision a way that mental health services and domestic abuse services can work effectively to support survivors? Should there be more roles created, like specialist mental health domestic abuse workers?
Yes. Short answer, no, definitely. I think you're right. There are again, it comes back to capacity. It's not the individuals in those services not wanting to work with each other. I'm sure most professionals do understand the concept of multi-agency working and would ideally like to do that, but there are systems barriers which prevent that from happening. So one of the things that I put in the report is that actually we should have embedded mental health specialists within DA services, and we should have embedded DA specialists within mental health services or secondary mental health trusts. Again, that comes down to a funding and a resource thing, but actually if we can get those multidisciplinary skills within individual organisations, that's easier to manage than having to go multi-agency every single time.
Thank you. And staying on the theme of multi-agency working, a request, I'd like to understand the MARAC recommendation further, please. I wonder if you could elaborate on that one.
Yeah, absolutely. So I'm coming from, my background is suicide prevention, not domestic abuse. So apologies if I talk about MARAC in slightly wrong language or whatever. But certainly in Kent and Medway, we've just reviewed all of our MARAC processes, the way MARAC meetings are held, the way MARAC caseloads are held and actioned, and also a number of the bits of paperwork that accompany all the MARAC pathways. And within each one of those, we've made sure that not only is the risk of harm from the perpetrator considered, but actually the risk of harm of suicide of both the victim and the perpetrator, interestingly and appropriately, I think, is reflected in all of those bits of paperwork, in all of those processes, in all of those referral processes and criteria. So it's just as simple as whenever you've got a bit of paper or a policy that talks about MARAC, you make sure it includes the risk of harm of suicide as well as the risk of harm from the perpetrator.
Thank you. Another question, by any chance, did you manage to look at suicide cases where victims of honour-based violence had supposedly committed suicide? The list of perpetrators would extend from intimate partner to potentially in-laws of victims' immediate or extended family.
No, short answer is no, I didn't. Longer answer is absolutely. That's an issue that I would support further work being done on. There has been a couple of high-profile cases in the press recently where I'm not sure whether they were honour-based violence cases or not, but certainly where the family of the person who's died in alleged suicides are convinced or certainly have questions about whether actually it was just a murder that was made to look like a suicide. I think the crucial point here is A, more research, and then B, the police response. And one of the recommendations that came out of the National Police Chiefs Council work last year was that when police are attending suspected suicides, they should be thinking about domestic abuse every single occasion in every single suicide and trying to eliminate the possibility that domestic abuse was involved. Again, going back to there are better social workers and some not quite so good. I'm sure the same applies to police officers. There are some police officers that will be doing that in every suspected suicide they attend. They will be thinking about, is DA involved here? Might it be homicide? May we be able to go down the Kienna Dawes route and charge with involuntary manslaughter? And there will be other police officers and other police forces who aren't quite there yet. But again, that's another area that I hope national action can be taken.
Thank you. And a question about the fellowship, actually. How and why did you choose the countries you visited during your research? And I wonder if I could add to that, what was in each of those 3 countries, what was the main thing you would take away from those 3 countries?
Yeah, so the first 2, Iceland and Slovenia, were very conference-based. So it just happened to be, so Iceland was the European Domestic Violence Conference in 2023. And then Slovenia, there was a global congress of suicide prevention happening in Slovenia. In terms of those 2 places, obviously they were conference-based. And what I took was that there are a huge amount of people doing work that's kind of related in this field. But very few of us are joined up. So we need to come together more often, which is why things like this today are fantastic in trying to bring people together. And then America, I chose America because there's a fantastic charity based in Chicago called, and I'm going to get this wrong because it's about 2 months since I've tried to talk about it, but the National Center for Mental Health, Trauma and Violence. And it's the only charity in the world that I could find that brings together and is 100% focused on the mental health impact of domestic violence and IPV. So I based my whole trip around there, and then went to other conferences and did spoke to other people on that basis. It's a simple answer, I guess, a bit blasé, but in terms of the thing that I mainly took from the US swing of my fellowship was guns. And guns play such a massive part in both domestic abuse and suicide prevention over in the States. It's a very the readily accessible. I mean, there are guns everywhere, literally in supermarkets selling guns, and just trying to have conversations about DA, IPV, and suicide. So much of it comes back to guns, because if you can take the guns out of relationships, then the risk of serious harm, either murder or suicide, instantly reduces in the States. So yeah, that was my main reflection from the States.
Thank you. I think we have time for one more question. So I'll ask, and I'll ask you to explain what these two things are, actually, because I'm not sure that everybody on the call will know both things. Is there a concern that the DARA does not ask the question, are you feeling depressed or having suicidal thoughts, like the DASH did? So if I can just ask you to touch on what the DARA and the DASH are, and also address that point, please. Yes,
absolutely. Sorry, and the puppy is barking at a squirrel which disappeared out the garden 30 seconds ago. The DARA and the DASH are risk assessment tools that police use, domestic abuse services use, social workers use to try and assess the level of risk that individuals face mainly from the perpetrator. And the question, yes, my answer to the question is yes. I am concerned that neither of them actually asked the questions about suicide in appropriate ways, I think. So the DASH that we use down here in Kent and Medway asks the question, are you feeling depressed or suicidal? That's not an appropriate question to ask. For a start, it's two questions. If somebody says yes, what are they answering yes to? Are they answering that they're depressed, or are they answering suicidal? And then if it is about yes to being suicidal, well, what does that mean for that individual in that moment? Are they just thinking, well, I don't mind if I don't wake up tomorrow, because for some people that's feeling suicidal? Or are they meaning, and this is obviously a whole continuum, are they thinking, actually, I've got a method, I've got a method, I've got a place, and my life is going to end in this way on this time frame? The responses professionals are very different according to what they actually mean by suicidal, and therefore whatever, either it's the DASH or the DARA or any other tool, it can only ever be a starting point for a conversation. And that's what some of the further templates in my slides are ways that you can then go on and have that further conversation and try and understand a bit more about what that person may mean if they say they are suicidal. But yeah, I think a lot of work needs to be done in the risk assessments that we use. And my final point on those actually is quite relates to the need for both of these sectors to come together, because obviously the domestic abuse sector is very well used to things like the DARA and the DASH and other risk assessment tools. The suicide prevention sector is almost universally opposed to risk assessment tools. And so they use very different ways of trying to understand risk, and actually trying to combine those two approaches into something that works for this cohort of people will need both the DA sector and the suicide prevention sector to come together and discuss what those appropriate tools and techniques may be.
Thank you, Tim. We have talked right up to our 45 minutes. Thank you, everybody, for such insightful questions, and Tim for handling them so adeptly. It's great to extend your presentation with that discussion. Thank you again for such an important, powerful presentation and the work that you're continuing to do in this area. I'm not sure whether you're keeping an eye on the chat, but there's lots of warm feedback coming through, lots of people who would like to be connected with you to discuss further. So we will try to facilitate that as best we can. I have popped in the chat just an invitation. If you have signed up to the webinar today because somebody forwarded an invitation to you, you can sign up to the Violence, Abuse and Mental Health Network to receive our monthly newsletter and invitations to events such as these. So please do follow that link to do that. Please do also consider rejoining us in February for next month's webinar, which is on minoritized survivors of experiences of mental health in the context of violence and abuse, with Samantha Roy from IMCAN and Ravi Chiara from University of Warwick. Just really to say, give my thanks again to Tim for joining us today, and we shall share those resources as promptly as we can with all of you. Thank you, everybody, and we hope to see you again at another one of our events soon. Take care, everyone.
Is that okay? Are we still, don't know.